What's up, guys? I'm Sarah.
And I'm Haley.
And we're
the Device Girls. Our mission for our podcast is to inspire and empower,
educate, and learn all about the medical and healthcare industry as a whole.
So tune in, and we hope you enjoy this episode.
Part 1 was just the beginning, so we did what any good surgical team would do. We scrubbed back in for more. Let's get into Part 2 with Dr. Bennett.
Okay, so you guys want to know a little bit about breast augmentation?
Yes.
All right, and breast implants. Fabulous. So I love talking about all of my work, obviously, but this is especially fun because I have props. And so I think the important thing for people to realize is that there's a lot of options out there.
Mm-hmm.
And so that's why we spend so much time with our patients and consultations, because we want you to be as educated as possible to make really great choices so that you feel comfortable and safe with the choices that you've made. The good news is that we do have different types of implants, different shapes, so that we can fit the different types of bodies. Because I mean, look at how petite you are. And then we've got somebody who's 5'10" or 6 feet tall, and they're just not going to have the same.
Like,
yeah,
I'm 5'8".
We have you.
Exactly.
And so, perfect example of why we need to have implants that I call them smart implants.
Yeah.
Only because, I mean, really, the doctor's the smart one, but really, the implants are so helpful because we want to fit them to your frame, because different people have different objectives.
Mm-hmm.
So as we've been talking about how plastic surgery has kind of had a pendulum where it's it was super like bigger was better, butts were in, big boobs, big butts. And then now we have the pendulum swimming back to more of the yoga aesthetic. We're seeing people who are doing much smaller augmentations. They want that lean, mean body. They want to look like the Lulu commercials. And so we're seeing kind of that swing back, which I actually love because I've always been more of a natural person kind of myself. And so the implants can help each person kind of achieve the shape that we're looking for.
Right.
So yes, we can do very, very big, but then we also can do very natural and something that looks just as if it was a part of your body. So what I have in front of me, I'm going to have you use your hand as well. So these 3 implants right here are actually all 300cc implants, but they look remarkably different. And so I like to show this to people because when someone comes in and goes, well, my friend got 300s, I want 300s. You're like, okay, first, let's back up. Let's see what you started out with. And then we're going to also look at your anatomy, and we're going to tailor, this is going to be your breast aug is going to be tailored to your body and your frame. So if we tilt them down, so you can see projection, and then when we tilt them down, you can see the width. What we want to do on our patients, and I'm going to set them down so I can talk. So our chest width is our frame and our ribs. We want to fit the breast implant so it fits on your chest wall, and so that we're not filling up your armpit so you feel like you're rubbing into your implant, or that you look really wide. Now, some ladies do like the idea of having a wider breast, narrower waist, and wider hips. So we absolutely can make the implants come a little wider if you want to do that. So some ladies will come in with pictures and they'll be like, I love this side boob. I love how this looks in that dress. Okay, great. If that's where you're going, then we'll do that. But in general, most of our ladies who do have wider breast implants tend to feel heavier. They tend to feel fatter. And when they wear their clothing, they really have to tailor it to make sure that it shows they have a tiny waist if their breasts are very wide.
Does that adjust? I'm assuming that makes an adjustment to your bra. It because I mean, the cup part is the depth, right? Okay.
So in general, if we're augmenting you, the 32, the 34, the 36, that's not going to change. It's your cup size. Now, granted, how you may wear that bra or what bra fits better may be a little different.
Okay.
And we do ask patients when they come in, what cup size are you? What cup size do you want to be? But people are remarkably poor at knowing what actual size they are. But it does.
That'd be me because I wear a sports bra almost every day.
Me too.
But what I like about it is that it's giving me some insight into number one, what they think they know, what they want, and what they think they want. But what we're going to do in our office is you're going to actually try on spacers and sizes of the different shapes and of the different sizes until you see what you like. So with those implants that I just showed you, what we want to do first with all of our patients is figure out what their anatomy is. And so with the physical exam, we're going to look at what their base width is. Once we know what that width is, we're then going to provide a continuously progressive more projection. And so that's why I showed you these are all 300s. And when you look at them this way, you can see that these are narrower. So what we would start at is, let's say this was my base width. Well, we would start with this moderate profile, bring that into for the patients to try on, and then we would go into the high profile, but with this base width, and then the ultra high profile.
Okay.
So once we set your base width, then we're going to work on our projections. And so that's why a 300 on one person isn't going to work on the other person, because if that doesn't fill your base width, then it's not going to look right.
Right.
So imagine you're a 10'8" size person and you come in and say, I want a 300, and we just pull out this tiny little ball. So that's just going to fill out the bottom part of the breast, and it's going to look like really weird with a tiny little ball at the bottom of the breast. We need to make sure that we pick an implant that has a broad enough width that's tall enough so that you don't feel like your breasts are hanging way down. We want to make sure that they give you that nice transition from your collarbone and then to your breast implant. And so you would need a taller implant. So that's when we start looking at what is the fill of the implants. So there are gummy bear implants, and they have different cross-linking. So depending on how cross-linked your silicone is, determines on how firm they are.
Okay.
And so for someone such as yourself, if you're saying, I don't want to be big, I just want to go up a little bit in size, well, we don't want to do a big, huge ball. We want to pick something that's going to give you a little bit of projection, but it's going to keep that upper pole fullness. So if you can look at these here, you can see that these are both 300cc implants, but you can see how much taller the implant is in my right hand, because this jelly is what I call puddling. It's the softest of the silicone gels. And since it puddles, it's not going to stay up tight and give you that upper pole fullness. So particularly in someone who's taller, we're going to recommend, especially if you're not wanting to go bigger, to go with the more cross-link boost gel, so that we can make sure that you're filling that upper pole. And so this is where it's so important to really engage with that person and get the conversation rolling of what they're looking for and what they want. Because if someone comes in and says, I want to look augmented, I want to look like I have, a ledge and I have upper pole fullness, that's going to educate me into, okay, not only do I need a larger implant, but I may also want the more cross-linked implant as well. And then if I have someone come in and go, oh, I just want to look very natural. I just want to have a little bit of fullness come back in there because I've lost weight, I've gotten leaner, or I just, I don't want any ledginess. And so we kind of play with that. And then I also talk to them and I say, the good news is you're going to try these sizers on right here in the office. You're going to be able to visualize yourself, and because sometimes people come in and they go, I know I want an augmentation, but I really have no idea what I want. So those are the hardest ones, because if they're not giving me any feedback, well, then it's really going to rely more on them visually seeing it and things like that. But
so you love when they come with pictures.
I love that too. Yeah, absolutely. I mean, my feeling is that the better educated a patient is, the happier they're going to be with their surgery. It breaks my heart when I have women come in who tell me that they went to see a surgeon and they were like, I wasn't allowed to try an implant. I was told I wasn't going to get to pick my implant. I was told to just tell them what cup size I wanted to be, and he picked. And I'm like,
what are the sizers? Like,
they're these ones that I have sitting right here.
Oh, okay.
And so you just have them put them in their bra cup. Okay.
And so we have a sizing bra and t-shirt, and we allow you to do to put them in there and to kind of do the shaping and look at what it looks like on their frame. Now, we absolutely can offer 3D imaging where they can do look at themselves and have a computer do it. It's through the Mentor, the company that does the breast implants.
Wow. Okay.
I know. So if you want to do that, we recommend it too. However, I don't think that the AI is great, but the AI is not yet good enough to figure out, in a simple person who doesn't have any loose skin, it's going to do a very good job of giving a prediction of, like, if they come in, I call it my Hershey Kiss patients. They just have a nipple with a Hershey Kiss and that's it. Then it's going to do a great job stimulating that. But for our ladies who are a little bit looser, saggier, it's going to be harder for them to kind of figure out breast aug alone, breast augmentation with lift, and what is my real results going to look like. So that's why I really like the spacers and sizers, because you're looking in the mirror, and that's what you're most used to looking at. You're not usually used to looking at your own avatar.
Right. Yes.
But if it helps people, we have it. It's just something that we can offer. But this is the most powerful tool, I think, because I tell them, So again, education is my biggest thing. And I tell them, we want you to feel as comfortable with what you're choosing before you actually have surgery. Come back as many times as you need. And we can also put you in the room with the spacer sizers, and you can do that as many times as you feel comfortable. Bring someone if you want to, but don't bring someone if you don't want to. Because we want you to, it's for you. It's not for somebody else. And so that's I think just one of the most comfortable ways, seeing themselves in their own clothes. We encourage them to take pictures of themselves in their own clothes so that they can kind of see. And sometimes people are better at pictures than they are at looking in the mirror. So having those pictures to kind of review at home and be like, okay, I like this size, but when I'm in that one, maybe that looks a little too big, because sometimes we're more used to seeing pictures if we don't look in the mirror very often, which a lot of us don't do.
Right.
So, and that's part of the education process as well, is making sure that patients, we're all asymmetric. So we all have one side of our face that's different than the other side of our face, but we all have one boob that's different than our other boob. And so making sure that we go through all of that and talk about how anatomy affects their results. So for instance, our inframammary folds are the bookshelf that the implant's going to rest on. So when we were talking about your length of your chest, someone who's shorter is going to obviously have a shorter chest width. And so that's why you don't need as tall of an implant. Someone who has a long chest, if that inframammary fold is low and they're saying they want their implants up near their collarbone, I'm like, unfortunately, what God gave you is going to affect what we end up with. And so making sure that someone with a longer chest understands, well, the taller silicone is going to help fill up that upper pole, but that that there are only so many tools in our toolbox. And if your inframammary fold is low, then this is where that implant's going to rest. This is where we're going to see our cleavage, and this is going to be the spacing of their chest. And so I love that it's mathematical as well. My mom was a civil engineer, and so there's the science and then there's the art. And so I love that it blends all of that together. And people are always shocked when they're like, wow, look at all these measurements. I'm like, oh my gosh, this is crazy. So
wow. Okay, can you talk about the difference between a silicone and saline?
Absolutely. Yeah. So here is a saline shell, and then we have 2 saline implants that are filled differently, just so that you can kind of get a better feeling for, again, moderate profile versus high profile, so that we can achieve different looks based on the implant style and design. The silicone shell and the saline shell are fairly similar. The difference is, so they both have the seal at the back, which is where they make the outer portion on the drum, and then they put the seal after they fill it. With the saline implant, on the other side of the saline implant, we actually have this little valve here, and that's how we're going to be able to go through a smaller incision with a saline implant, because you roll it up like a little burrito, put it through that small incision, and then you unroll it, and then there's a little fill tube that comes. I should have brought one for you, but the little fill tube, then we fill it up to the volume that it's that we want it to be. So that's going to be your saline.
What's most popular?
So in terms of now, usually silicone is our more popular option. It is important to realize that when you have a saline implant, it is a silicone shell. And so that silicone shell is still silicone. If people ask about, well, what one's safer? Well, it's not so much what's safer. It's more about what makes you feel comfortable and confident. So with the saline implants, obviously the good news is when they rupture, you know they rupture because you'll go flat. The bad news is when you have a rupture, you know you have a rupture because you'll go flat.
Yes.
So with the saline, if that gives someone peace of mind, then we definitely want them to go with saline. And that's, we have a graph that I give them of the differences between saline and silicone. And so that's one of the things we talk about. So if rupture is going to be an issue that you want to make sure that you know that they're ruptured and that gives you peace of mind, and then saline is going to be the one that's going to give you more maybe peace of mind without as much follow-up. If you choose to follow the silicone, I'm going to teach you ways to follow your silicone implants so that hopefully you yourself can tell if you have a rupture, just by moving them in the pocket and doing some different massage techniques. I can kind of oftentimes tell just on physical exam if the implant's intact with silicone. And I try to teach my patients that. So I think that's important. But if you want to know and the saline gives you peace of mind, then great, we're going to go with saline. Unfortunately, the downside of saline is that as you have felt this here, you can tell, and maybe patients can tell by looking just at the video, you can see that it is a firmer, harder feel for a saline implant, because it truly is saltwater bag filled with salt water.
Mm-hmm.
And so that feeling of that is not as
Natural.
natural as the silicone is.
Right.
And it doesn't feel as much like breast tissue.
Right.
So for patients who are really concerned about feel and the fakeness and feeling like they're more a part of their body, if that's going to be higher on the their concern list, then they're going to probably be more interested in going with a silicone option so that they feel more natural and don't feel like they're constantly reminded that they have implants in place.
Right.
So many of our patients at the 3 months, they're like, I just feel like they're a part of my body. I just feel like I've always had them. I feel like they're me.
Yeah.
And that's what we want, is for them to feel like they're just part of their body.
Yeah.
So you're talking about rupture. What are some of the main causes of implant rupture?
Oh, sure. That's a great question. So with any device, or let's just take a paperclip.
Right.
When you take a paperclip and we unfold a paperclip and we go back and forth and we bend that paperclip, eventually even metal was going to break.
Mm-hmm.
So silicone shells are a firmer form of silicone, but as you can see when they're sitting here, they fold. They they fold. So when you see that fold, what's going to happen over time is it's going to weaken along that fold. So now take a piece of paper, we fold it in half, we open it back up. That fold is still there. You can still see where it creased. It doesn't go back to being that flat piece of paper we had.
Yeah.
So same thing with the implant shells. The implant shells fold and they end up getting that crease, and over a long period of time, that crease can end up weakening, and you can get a small tear there.
Okay.
So, now on the saline implants, the other thing that we see is that because of this valve, if let's see if you can see it on camera, there is also this little tiny I don't know, scientific term, nubbin. I don't know.
Okay.
There's this little tiny dot that's in here that actually goes down to cover the valve where we place that fill tube.
Uh-huh.
Okay.
And that little tiny piece of silicone that goes over to cover it, the cap, I guess it's a cap, is going to help the scar tissue from not growing into that valve and causing a slow leak to occur.
Okay.
So if somebody tells me that their breast is slowly getting smaller, then they probably had saline implants and they probably had just an ingrowth of the scar tissue into that. And they've ended up getting a small leak.
Oh, wow.
Typically, most saline are going to just, I woke up one morning and I was fine the night before, and I woke up in the morning and I was wet. And that's just because the salt water absorbs that quickly. Once it's exposed to your body's like, oh, I'm thirsty.
Yeah.
And it just sucks up that saline.
Okay.
So, but does that make sense about the tearing?
Yeah. But so since saline is saline, that's obviously like fine for your body. But what about the silicone if it ruptures and leaking?
Absolutely. Good question. So in the 70s and 80s, initially silicone implants were a full-on liquid silicone. And so, we did worry and saw more evidence of when an implant ruptured that liquid silicone kind of got into the pocket. I guess I need to back up a step. So whenever we have a foreign object in a body, we our body lays down a scar around it. So whether it's a pacemaker or an implant, our body creates a scar, which we refer to as a capsule, around that implant. So that scar is basically walling off whatever foreign object is there. And so that capsule in general, even with these old liquid implants in general, would contain, if the implant shell ruptured, contain that liquid silicone, or nowadays the jelly silicone. So the capsule itself, our scar tissue, is going to keep that silicone usually from going elsewhere. Now, unfortunately, because those implants did have liquid silicone, there are times when ladies who've had them in for 30, 40 years and they were ruptured, the scar tissue, let's say they have a trauma or they fall or they're in a car wreck, and then they break that scar capsule, and then that liquid silicone can seep past or extracapsular outside of that scar tissue. And so we do see that can happen. In general, it's usually going to just wall off right there around it in that little section of that breast tissue. But if someone neglects it, and unfortunately, a lot of those ladies back in the 70s and 80s were told it's a one and done surgery. Once you have the implants in, you're never going to need to do anything else. And so they've just not done anything with them. So we certainly recommend for those patients with older implants and people with implants now, once you know your shell is ruptured, please get it changed out so that you don't have to worry about anything else. At the microscopic level, of course, we hear people talking about finding silicone in lymph nodes and things like that. But I think that's the case. I mean, whether you get a pacemaker or a breast implant is going to have the same thing. But we never hear people talking about, silicone problems with their pacemaker.
Right. Yeah.
So we do feel that it's very inert. We do feel that it's very safe. But in general, when you hear about people talking about, that it escaped into my body, it's usually just locally right there in the in that outside of that scar capsule.
Okay.
Now I should have brought mine that I cut. That we love that the implants are now more of a cross-linked jelly because now if you do have a rupture, it's even so jelly-like. I love it. I can squeeze it in the office and it you see the little ball and then it sucks back in. And so when you have the silicone gel, it's called memory gel because it keeps its shape. It wants to stay in the shape that it is. And so I think there's nothing more powerful than being able to show that to our patients that jelly is more cross-linked, that it's going to stay there.
So it's not even like liquidy at all.
No.
So it literally is like a gummy bear.
So it is like a gummy bear.
Okay.
And the more the cross-link, the harder it's going to be. Now, I will give you the caveat that when we go in the operating room, if someone has had one of these gummy bears and they've had the implant in there ruptured for a while, we do naturally have some of our body fluids that are just serum, part of that bathe all of our tissues. And so if they've had a rupture for a very long period of time, then some of that fluid does kind of mix with some of the gel. And so we will have a little bit more of a jelly in there. And when we pull the implant out, if it just has a small tear in it, it's crazy. It's just all encased within the shell. But if they've let it go for a long period of time and more of the shell is ruptured, then it will kind of come out and it will have a jelly component as well as more cross-linked gel.
Okay.
But the nice thing is we just go in, we take our lap pads or our cotton pads and we just wipe that out of there and we put a brand new implant in and they're done and they're good to go.
Okay.
So our older ladies who had the liquid silicone and who have let it actually get into their breast tissue, for those ladies, or we've had capsular contracture, which is scar tissue that is now hardened and become really calcified. We're usually going to do a capsulectomy and we're going to remove that calcified scar tissue and any of the associated breast tissue that we feel has silicone in it. But I tell my patients that silicone is clear and the only way to see it is actually to feel it. And so if it's a hardened area of breast tissue, fat and breast tissue, then I'll remove it. But if I can't feel it, and I can't see it, my eyes aren't x-rays. And so for some of those ladies, I tell them you may always see on your x-rays, even though we put brand new implants in that are intact, you may always see a little bit of that in the tissues afterwards.
Okay.
The good news is that our usually our older patients are ladies who have kept their implants for 30 or 40 years. And so we're not talking about the newer implants as much.
Okay.
But I did bring another toy.
Another device.
So, yes, because you guys were device ladies. So do devices. So I love this. This is a Clarius handheld ultrasound. And so just with safety and surgery, the Clarius devices are best known for two things in plastic surgery. So the first one is actually looking at implants. And so just like you were asking me, with the saline, we know that they're ruptured because they go flat. With the silicone ones, how do we know if they're ruptured or not? So we can use an ultrasound, and I love to provide this to my patients in my office for follow-up. So people are like, oh, why should I follow up? And I'm like, oh, because we can actually help you with that follow-up and know help you feel as confident as possible in your implants. So first I told you that on physical exam, we can tell if the implants are intact. So if the implant is floating inside the scar tissue and you are able to roll that implant up and down in the pocket and it's loose, then we can then check the implant by actually pressing on it. If you press on the implant here and you have another hand on it, it wobbles back and forth. I totally should have brought my cut one because if you have a cut and you push on it and then you push on it with the other hand, instead of having the feedback in the other hand, the jelly, like I said, comes out. Goes, I love that. So it comes out on the sides, and so you don't get that feedback. feedback in the other hand. So I teach all of my patients how to follow their implants so that they know how to do that.
Okay.
And it's just another thing that I love for my patients to have. We're in West Texas, so I get to see my patients back for their yearly follow-ups, and I feel like we're a small town, and so people are going to come back for their follow-ups. My identical twins in LA, and she's like, there's no way they're going to come back for a 1-year follow-up.
No way.
I'm like, well, I see them in the grocery store. So, I mean, like I said.
They're like, can we just check right here? Thank you. No.
I would be sitting there all the time like,
well, I can't tell you how many times I've been pulled into bathrooms. I've been pulled into
Oh my
closets.
gosh. Yeah.
Could you just check this for me? I'm like, sure, no problem. Let's go, girl. Let's do it. And so
Awesome.
they really do. And it's funny. So,
Oh my
but so
gosh.
with that feedback, if you rock and roll it and you don't feel that feedback, well, then we're going to be concerned about it. And so we can check with our ultrasound. Also, if somebody does have capsular contracture, that's when the scar tissue kind of gets firmer, tighter, harder around the implant. Well, then we don't know, are we feeling the feedback from just the implant being squeezed by the scar tissue, or is it really that the implant's intact?
Okay.
So voila, then comes in our ultrasound. And so what's really neat is I just pull the app up on my phone, and they have actually, Clarius has got an artificial intelligence specifically for our breast implant patients.
Wow.
And so you've all seen an ultrasound, they're gray scale. You see that darker colors in the light whites, and it's all gray. And you're like, I'm looking at a snowstorm. I'm looking at, it's like charades, right?
Yeah.
So what's really cool is they've got this AI, and it interprets the grays of shade, the shades of gray. And so on the top of the screen is the gray, and on the bottom is in living color. They'll see their implant shell is a dark blue. The gel on the inside's a lighter blue. Above that, their muscle is red, and then their subcutaneous fat and breast tissue is varying shades of yellow and tan. So it's really nice. I love it. I just whip that baby out, and I'll usually do my physical exam first, tell them whether I'm concerned or not concerned, and then we'll whip out the ultrasound and do that.
There we go.
Wow.
Yeah.
Awesome.
So it's kind of cool.
If I ever
That
got
is-
implants, I would need one of those at home.
Oh, there you go.
Pull up my app.
One of the neat things, I don't know if you guys have heard much about, so the big butt thing was all the huge rage, and Florida led the way on a lot of, Miami in particular, of those, the BBLs, the Brazilian butt lifts. And so unfortunately, it was a very unregulated space. And so they had, unfortunately, some deaths from fat grafting into the butts. And so Clarius also led the way, and some plastic surgeons there, because thankfully it was more of the Wild Wild West non-board certified plastic surgeons who were just doing so many Brazilian butt lifts in a day that they, couldn't physically possibly do it. They were having unlicensed people doing the surgeries actually, and they were supervising like 6 surgeries at a time. Anyway, it's crazy. So do your research, make sure you know who you're going to, and one day
board certified.
Board
Thank
certified.
you.
Thank you. Yeah. But anyway, so that it became so bad that the legislation in Miami actually has now deemed it necessary that all BBLs be performed with an ultrasound in the operating room, because you can actually see the different spaces that you're going to be putting the fat into. And we know that if people perforate and go below the gluteus muscle, that they're most likely to get a fat embolism, and that fat embolism goes to the heart and then causes heart attack, and they can die. So, but that's one of the neat things. The Clarius is also can be used for that in surgery. So you put it in a little sleeve, and you can actually bring it in there. You can also use it for tap blocks. So like all of my patients, all of my tummy tucks, we do a block where we actually put Exparel, which is a long-lasting 2 to 3 day block into the nerves on either side, so that they don't have as much discomfort in their tummy. And we do that with ultrasound guidance, so we know where we're at. So yes. So the ultrasound is a super helpful adjunct in our
amazing
plastic surgery.
Wow.
So
I love that little thing.
Can you talk a little bit about like what your placement of the breast implant, whether you put it above or below the muscle?
Oh, yeah.
Yeah, good question. Very good question. So breast implants are actually a worldwide thing. So we have millions of women who've had breast augmentations, and the US is very different than the rest of the world.
Okay.
So why do I say that? Well, in the US, when we had the moratorium on implants back in the 90s, they were worried that maybe the ladies were having more problems from their implants. And so we took all the devices off, and then they just started getting the FDA approval back in the late 90s. And so in 2004 was when we were allowed to have silicone back.
Okay.
Well, during all that time, they never took breast implants away from any of the international countries. So all of
Really?
South America, all of Europe, all of Australia,
Okay.
they've always had implants.
Mhm.
But their companies have always had slightly textured implants.
Okay.
And so their slightly textured implants can be placed in front of or behind the muscle and have equally good long-term results without causing capsular contracture. So capsular contractures when the scar tissue forms around the implant, making it firm, tight, and hard.
Mhm.
So if you have a textured implant, we know that rate is going to be a little bit less. And so then we can put it above or below the muscle, just depending on the patient's choice. In America, however, when they first got the FDA clearance, they just had the smooth implants cleared. And so we started doing all of our studies with the smooth implants. Mm-hmm. And the problem was that with smooth implants, with the companies that we had, we saw a lot, if we did it in front of the muscle, we saw a lot of tissue stretching, a lot of tissue falling, and we were at a much greater chance of capsular contracture happening. Okay. So we thought, wow, let's put it below the muscle. Let's see if that constant animation of the implant helps to prevent that scar tissue. Maybe if we don't invade the breast plane, maybe we won't have as much capsular contracture, and voila. When we went below the muscle, we suddenly now had equal capsular contracture rates to the Europeans and the South Americans and things like that. Okay. So since we were largely a smooth breast implant population, we ended up choosing more in America to go submuscular. Okay. So, then came the 2000s, and we introduced textured implants with two main companies in the US. Allergan was one of them, and Mentor was the other. Well, unfortunately, the texturing was, they were very excited about their texturing from the Allergan company because it was a super textured implant. And that super texturing, they felt like would really make it stick like Velcro so that you wouldn't have that descent of the implant and the bottoming out that we see. Unfortunately, what it also did was activate people's immune systems. And just like people who have, who get a stomach GI lymphoma, the patients, unfortunately, many of the patients who got those super textured implants, one out of, I think 1 out of 3,000 is unfortunately was diagnosed with lymphoma associated with their implants. Oh, wow. And so they have taken those off the market. But if you ever do hear about that, that's breast implant associated lymphoma. And it's specifically only to the Allergan implants. And so they do not feel that you need to remove them if you have them because the incidence is so low. However, if somebody were to notice that they had a breast that just started growing, that wouldn't be normal. Yeah, right. So please see a doctor. Yeah. And if they had a seroma, we now aspirate that, check to make sure that they don't have any cells that indicate the lymphoma. And the only treatment that most of those ladies who are caught early need is just a capsulectomy and removal of those implants. Okay. So the good news is there are not lots of those implants on the market, and the majority of textured implants are not those implants. However, in the US, again, because that was one of the two main companies that provide breast implants in America, a lot of people have just sworn off textured implants. And so in America, we are largely a smooth implant company. Okay. However, there is a new just brand new FDA approved implant company called Motiva. And it's big on social media right now. And it is also micro textured implant. And so just like, so Mentor, who I use largely, and pretty much all my implants are Mentor, unless someone has had Allergan before. Mentor's textured implants are also micro textured implant as well. But Motiva and then Mentor's micro textured implants are also, you can do those above the muscle, and hopefully have the same risk of capsular contracture as if you were going underneath the muscle with a smooth device.
So if you're a mom or a future mom, and you were considering breast implants prior to, like, what does breastfeeding look like?
Perfect. Yeah. So
that's a great question.
So honestly, with implants, whether we're going behind the we're going subglandular, subfascial, or submuscular. We're always trying to stay out of the breast tissue. And so as a mom, the concerns that we have obviously would be kind of cutting through the breast tissue. But we know that women who have breast reductions before they have babies, and we remove a lot of their breast tissue and cut through their breast tissue, 70% of them are still going to be able to breastfeed.
Okay.
And so when we talk about implants, people worry, oh, is the implant going to cause more of a bad effect than to the breastfeeding possibilities? But it's really not nearly as invasive as if we did a breast reduction on a 20-year-old who then has babies. The reason that we worry, obviously, is we want to make sure that people are aware. There's the potential for sensory nerve loss to the nipple with any surgery on the breast. And if you have less sensation to the nipple, then the nipple may not harden as much because it's not stimulated to tighten up. And so it may be harder for latching. Now, we already have ladies who have a difficult time with latching, even if they don't have breast implants. And so there's nipple shields, nipple guards, and there's pumping and things like that. So the good news is there are alternatives. There are ways if you want to make sure that your baby has breast milk to do that. But honestly, I do more educating on my patients about the side effects if they get a breast reduction in their 20s versus getting a breast aug in their 20s. I mean, we definitely talk about it on both sides. But I'm more concerned with disrupting their ducts doing a breast reduction than I am with an aug.
So I did not know that.
So the big terms that you'll hear in terms of placement of the implants is subglandular. And we usually kind of steer away from that with capsular contracture. So we're usually saying subfascial. We want to go below the fascia of the breast. So everything's contained in it. So when we do a mastectomy surgery for breast cancer, the general surgeon wants to take the fascia with the mastectomy specimen because the fascia is that demarcation between making sure you got all the breast tissue. So when we do breast implants now, we're going subfascial, so behind the fascia, or partially submuscular. And we say behind the muscle, but most women, if we think about the anatomy, so again, we talked about it, the inframammary fold. Our pec muscle comes across, inserts on the sternum. But then if my hand is like the pec muscle, there's the whole lower outer quadrant of the breast that is not covered by pec muscle. Your pec muscle doesn't miraculously fan out and cover all of it. And some ladies' inframammary fold is much lower than where their pec ends as well. And so there is going to be a portion of the breast implants that are usually subglandular, subfascial, that are not fully covered by muscle. So when we do go below the muscle, our bodybuilders, our workout people want to know about, well, can I still work out? Can I still go back to doing everything I want to do? Absolutely. You can definitely go back. And if you want to lift heavy weights, you're going to be able to lift heavy weights. Many of our patients are lean people, and that's why they don't have so much breast tissue, because 50% of breast tissue is fatty tissue. So if you don't have any fat on your body, you're going to have smaller breasts. And so all of those patients can go back to doing what they're wanting to do. Now, what I will say is, based on your anatomy, if you are submuscular, if your muscle's high, and when you flex your pec muscles, it doesn't like grab hold of your implants and push them down and out. Instead, let's say when you flex your muscles, it pulls them up. Well, then that's going to be a great setup for no problems down the road. If, on the other hand, you had a high muscle and a low fold, and every time you flex your muscle, it pushes your implants down and out, yes, you are going to see over time that constant working of those pec muscles is going to be like a water hammer effect and push those implants down, and you may feel like they sag a little bit more quickly than if you hadn't. So
what's the difference in how they look when you go like submuscular?
So it's going to be a lot about what people want. So, and also, again, their body structure and all those measurements I was telling you about. So one of the things that we also want to measure is called the pinch thickness. So if somebody is extremely lean and you pinch and they're just skin up above on their upper chest wall, and they have
like,
no,
pinch yourself.
I know, pinch yourself, pinch it. We usually say if there's less than a 2 centimeter pinch thickness, then you're not going to have very good coverage of the upper pole of the implant. And we worry about more visibility of the implant and being able to see wrinkling and rippling of the implant edge. I always kind of joke, it's kind of like you go, you know, it's gonna like all of a sudden skin and then implant. So we don't really want that. And so if somebody is extremely lean, then we're going to be more interested in potentially going below the muscle so that we have that coverage, so we don't see that transition. So a lot of those factors, like when we're doing that, the intake with patient, we're taking all of those things into account. What is going to, be each person's best outcome? What's going to look right on their body? And what do people want? Do people want that ledginess? Do they want that fullness? If somebody comes in and says, well, I want a ball in my chest, well, then we're going to approach that person very differently in terms of that projection and whatnot. Can we get that ball on chest look and go submuscular? Absolutely. Can we get a very natural look and go submuscular? Yes. We can do it in any plane. But we're going to choose different implants. We're going to choose to better achieve your desire.
Okay.
Right.
I just hear like some of the bodybuilders talking about, oh, I went under the muscle and what I'm like, what?
Yeah.
I don't know what the difference is.
that
But then
change?
some of them, when they're super lean, they just look like, so I don't know.
Yeah.
Well, and that's the hard part too with bodybuilding. And when people are trying to lose that fat for a show, for a competition, absolutely, you do not have that coverage. So if somebody comes in and let's say they're not even a bodybuilder, but they just are blessed with that
Super
physique
lean,
and they're just
yeah.
always super lean, and they're like, I really don't like that I see wrinkling and rippling of my implants. I'm like, eat some Oreos.
Uh-huh.
And they're like, oh, and I'm like, no, I'm serious. I'm only partially kidding, but really, the more fat you have on your body, the more you're going to camouflage that, the more you're going to be able to see that it fills that in. And so that's where fat grafting has been really handy. But again, in these lean individuals, where do we get fat from? Inner thighs or back of their arms, or where can we find it to try to thicken that skin flap? And we'll put layers of fat into that skin flap to try to thicken it up.
Yeah.
However, if they don't have a lot of fat to give, or they're just super lean, it's not going to necessarily be a good option.
Yeah.
But you have to realize, and that's why most people are going to see your implants in the upper inner quadrant.
Right.
So when we go submuscular, you've got that pec muscle now giving you some better coverage, so you don't see that wrinkling and rippling. But where do we not have it? Well, I just told you it's that lateral outer quadrant. How thin are you on your ribs out there? If you now have an implant and all you have is skin out there covering that implant, that is going to be the most likely spot for you to feel and or see the edges of those implants.
Yeah.
Right.
And so for our bodybuilders, people like, you shouldn't go, you would think, oh, don't go below their muscles because it affects their bodybuilding. But they're the ones, if they're going to be going to shows and stuff like that, and they're going to get so lean that they have no fat, if you've got it on top of their muscles, they're going to, those implants are going to really be visible because their skin is so thin without that subcutaneous fat.
Yeah.
And so that's what we talk to them about is, okay, well, what's more important? Is it, because a lot of them don't want to look like they just have an implant on their chest when they're competing.
Yeah.
So,
Does it change your surgical approach in how you go in or how you enter? I mean, do some people, can they pick?
Absolutely.
Like go into, okay.
So with the different surgeries approaches, the inframammary fold is the most common approach because it's hidden in the crease. And so it's directly underneath there. You're least likely to, get into any of the breast tissue. And so your direct approach, and you're able to kind of visualize the whole pocket.
Okay.
We can also do around the areola or underneath the armpit. However, most times when we go through the areola, we see the capsular contracture rate go up. Because
Really
remember, we were talking about if we go through the periareolar incision, we're going through breast tissue. Yeah. And so we feel like that capsular contracture may be caused by a little bit of those natural bacteria that are in the breast ducts.
Okay.
And so if we have that little bit of exposure to maybe a little bit of those bacteria, maybe it's more likely why we get capsular contracture in patients with that periareolar incision. It's a great incision though, because it hides between visibly when we're looking at them, the areola, that scar kind of hides along that natural demarcation of the darker areola and the breast skin. So it's also a good incision. And then the armpit one can be used as well. Unfortunately, malpositioning of the implants is most common through the axillary incision because you're now coming from way over here and trying to dissect out that whole pocket. And so trying to figure where your anatomy and your inframammary fold is and releasing the muscles is not as easy. And so if you do go that route, make sure that someone does it all the time.
Okay.
So, but I probably correct more misplacements of axillary incision paste implants than any other.
Interesting.
Just because of harder to figure out the anatomy. So I usually prefer, if the patient wants my opinion, the inframemory fold incision, because it's going to be very small. It's going to be roughly like 3 centimeters in size. And most people, only someone who really loves you is going to see that incision. Because usually we're going to have a bra or a bathing suit on, and we place it high enough in the crease that if you were to raise your arms up, let's say you're playing volleyball or whatnot at the beach, and you're not going to see that incision. What I don't like is if you're playing volleyball at the beach and you have an armpit incision, hi.
Yes.
And so I feel like even though some people think, oh, well, I don't want to put a scar on my breast, I'm like, well, who's going to see what part of your body more?
Yeah. It's
so
true.
The armpit one can be more visible. So
very true.
Interesting.
I love this. We're just getting deep in the boobies.
Oh, so I should tell you about fat grafting, right?
Yes.
Okay.
Absolutely.
So for those people who don't want to do breast implants, fat grafting is so exciting. We've been doing it now for at least 20 years. And we actually started out in our breast cancer patients using it for patients who've had a mastectomy, who may have a mastectomy abnormality or irregularity of their mastectomy skin flap. So they didn't necessarily need, or they already had an implant, but they needed more tissue coverage, or they needed where a spot was like more hollow, some volume. And so just like a skin graft, we can take skin off one spot and we can help heal burns. We can help heal wounds. That skin now gets its blood supply from the new wound bed. Well, same thing with fat grafting. So with liposuction, we're taking tiny little pieces of fat because it's very brutal if you've ever gotten to see it. If anybody comes to me and they're like, oh, I've been watching liposuction and I'm ready to have it done, I'm like, you are brave. You are definitely brave.
I've watched some videos.
I have too. Like the BBLs, they look rough.
Yeah.
Like that.
It is not easy. It is definitely sore. But it is amazing that we're able to take that from one spot of your body and have it survive and move it. So like 25 years ago when I started, people would be like, well, could you just like take the fat from my belly and like put it in my boobs or where I want it? And I'm like, no, we can't do that. And now I'm like, yes, we can. You can do that. And so when we're doing the liposuction though, as you've seen in those videos, we're using basically a tube of metal that has little holes in it. And so it's like a little vacuum. It's a fat vacuum. And we're going to take that and help to contour the region that somebody has maybe more fat than they want. So we try to go for places that people don't like: hip dips, inner thighs, lateral thighs, the love handles. Oh my God. Hormones in women, we get love handles, and men are the only ones supposed to have love handles, right? No offense, guys. As we get more into menopause, and that's another big thing for me. I just love being able to work with these ladies who have worked so hard on their shape, and then now they are getting fat where they've never had it before. And so we can take that fat and we vacuum that out into little tiny particles. And then as long as we transplant it to a place that has good blood supply, it can actually get its blood supply, its nutrients from the tissue around it. Little blood vessels can grow into it over a 2-week period. And so that's incredible.
Yeah.
Now
our bodies are so cool.
Yes. Now one of the things that's kind of like too much, of course, is with some of those BBLs you may have seen, like they make these ginormous butts with these fat grafting. If you put too much fat into a recipient site that doesn't have enough blood supply, the fat's just going to die. And so it may look good on the table, but that's not what you want to look at. You want to look at like 3-month, 1 year post-op pictures, because I can stuff as much fat as I want into an area, but if it's not going to survive, I haven't done you any good.
Yes.
Right.
So with the breast, that's why it's so important in terms of the recipient bed. So if somebody comes in and they are little tiny, Hershey cut breasts, don't have a lot of loose skin, and they are tiny and they don't have any fat, they're not usually going to be as good of a candidate for breast fat grafting, because number one, they don't have as much of a donor site, and they're always so cute because they're like, oh, I have so much fat. And you're like, okay, let's be realistic.
Yes.
You really don't.
Yes.
And so that one may not be as good of a candidate. And so we may want to do implants if they're set on it, we can do serial fat grafting, and that's no problem. We're able to slowly expand the breast skin and the breast with fat to get you more the size that you want to be. But if somebody wants to go from like an A to a D, we're not usually going to be able to do that in a single fat grafting scenario, because we again have to have blood supply and nutrition from the fat that we've grafted there. So what we talk about doing is droplet droplet therapy. We're dropping the little droplets of fat, and we're crisscrossing in multiple levels and planes to make a 3-dimensional matrix of fat inside that breast, and help fill it out.
Wow.
And so it's really great because it helps to build a new breast that is the same shape as what you had, just fuller. And so that's really nice. And we can focus. Like if somebody's like, well, I just feel like I want primarily upper pole fullness. I really like the rest of my breast, but I just feel like there's a long takeoff on my chest before I see that natural, ski slopes. I want to have it a little higher. Well, we could fat graft just the upper pole. It doesn't. And so it's nice. You're not just sticking a ball in someone's chest. It's a designer breast augmentation.
There you go.
And so we can kind of do that. And honestly, some of our moms who've breastfed and now their breasts are softer, not as full, are going to be great candidates for that because now their skin's expanded and there's room to take on more of that. And so the recipient site and the donor sites are going to be really important in terms of picking that. But I love that we can offer something other than breast implants. And for people who are worried about breast implants, we have something other than breast implants to help them get more volume.
Wow.
So that's amazing.
That's so cool.
So, so what is your favorite? What's your favorite procedure type to do, or do you have like a?
So when I came to Abilene, I really started out as wholly reconstructive and really did all of that. But my practice really has sort of evolved more into more of a cosmetic practice. So probably 70% of my cases are cosmetic and 30% are reconstruction. I love that. When I was younger and I used to talk about reconstructive surgery, it is a passion and I love being able to help people that way. But also cosmetics was also a little scary because it was taking someone who's perfectly fine and trying to make them better.
Right.
And so when you have someone who has cancer and you're reconstructing them, anything you can help them with is going to be wonderful. But with cosmetics, that attention to detail, that desire to make something that's not broken better adds an extra element of stress, an extra element of finesse that you need to have. And so I have definitely loved evolving into more of the cosmetics just because it has made my skill set. You have to be so precise. And I love being able to do both, but I do think that the cosmetics is a passion. And I do think that a lot of my patients relate to me as a female and they love having a female plastic surgeon. And you do have to really, you have to get naked for me. I'm sorry. I have to see you. And so we are our most vulnerable when people come to me, and I want them to feel as good as they can and empower them and feel, I do try to make sure they know about them, how good they do look and the things that are good and that we are going to be able to help them and that it's not necessarily their fault. I mean, we had babies or, we have that loose skin and no amount of working out is going to make that loose skin go away.
Right.
And we have that diastasis and it's not going to repair all by itself. And our breast tissue atrophies after we breastfeed. And so you're not necessarily going to have those breasts come back to those freaking 18-year-old breasts without doing something for you. So making sure that they feel empowered to know that there's choices, that they can make their lives better, and that it is okay to feel your best. We have a lot of mommy guilt, I think, and we have constantly taken care of other people in our family. We're always putting other people first. And so it's really, a lot of them are battling with that of doing something for themselves. And they are concerned about that guilt. And so also acknowledging that, making sure that they feel really comfortable, that they're not alone and that it's okay to do something for themselves. And it's going to just make the people around them that much happier because they're going to feel that much better about themselves. And so for me, the surgeries that I do most commonly are going to be mommy makeovers and any element of that. So breast reduction, breast lifting, breast augmentation, breast organ lifting, and then the tummy tuck, the liposuction, the liposuction 360, and any combination of that is going to be like my most common cases. And I just love all of them because it's so rewarding when they're sitting back in my office after surgery and they're just so excited and they something that's been bothering them for so long can be lifted from them. And I just love being able to feel that. So those are the kind of like I said, the haves and the have-nots. We have the people, everyone's kind of trying to get to that happy medium of what makes them feel best in their body.
Absolutely. I love that. I'm so excited to talk about filler.
Okay.
Yes.
Well, this is a great topic. And so it's something that we see a lot of. I think, again, like the big boobs, it was also big lips. And so I think that also those scared a lot of the population. And so I love that we're again swinging back to a more natural look and trying to just help people age gracefully instead of like looking like somebody else.
Yeah.
So I love that, that we're kind of leaning back into just rejuvenation and feeling like your best self. So there is a lot of different implant or filler types out there, and there are different companies that sell. But the main, most common that we hear about is going to be your hyaluronic acid based fillers. So why hyaluronic acid? It is the natural moisturizing element of the skin. So it's already in your skin. It's already something that you have. And as we get older, we have less of it, but we also have enzymes even when we're younger that are degrading it. And so when we have less of that hyaluronic acid, we have less of that moisturizing component in our skin and our collagen. So what the amazing scientists have done is they have cross-linked the hyaluronic acid so that it can be thicker or thinner. And that thicker or thinness is going to help us to figure out where we want to put the fillers in the face. So now there are other families of fillers, and I'll talk about those next. But first, since we have show and tell, we'll talk about this one first. So when we look at a face, you can already tell just by looking at somebody that the thickness of our skin is very different in different parts of our face. So we have our eyelids, right? When you pinch that skin and you look at that, an eyelid is very, very thin. And then we go into a cheek and we have some more thickness there. And then we go to a lip, which is kind of in the middle. And so each of those areas needs to be treated differently. If you only have a hammer, everything's a nail. So we don't want that. We do not want that. That is not good for faces. That's
a great analogy.
Yes, exactly. So we need our screwdriver and our saw and our wrench, all of the different things. And so people need to be adept at using all of those different fillers for your face. So the companies have also generated both not only different thicknesses, but because of those thicknesses, where they need to be placed. So I'm going to talk primarily about the Allergan company, the Volbella, Voluma, Juvederm, but you're going to see the same thing if you've got the other companies have Kiss and Lift and then there's so many different, then there's RHAs and yes. And so whatever company you hear talked about, most of them are going to have the different cross-linking in their hyaluronic acid. So they have different thicknesses and softnesses to be used. Okay. That's kind of the concept behind it. Thinness, thickness. So the more cross-linking, then there's also more of a lifting capability. So a thicker filler is going to need to be placed deeper so that it can function as a lifting component. And then your thinner fillers can be placed more superficially, maybe more in the subcutaneous fat or in the skin themselves, even in the layers of the skin. So each of those is going to work differently. The thickest and deepest of fillers are going to be helpful for maybe remodeling of the jawline, getting that snatched jawline, chin projection. As we age, we lose a lot of volume of our mandible. And that's actually kind of where fillers started, was that we were supposed to be trying to fill in the volume loss that we get when we age. So they've done MRI studies of the head to see the changes over time of what's happening. And what we found is that not only do we lose soft tissue, so fat pads sag, but soft tissue pads, fat pads can also decrease in volume, but we also have a skeletal loss. So around the nose, that piriform aperture actually gets bigger. We see volume loss in the cheekbones. And the orbits expand and get bigger, so more hollowing around the eyes. And then we also see our mandible get smaller, and particularly for people who lose teeth or have poor dentition, they're going to see a much more rapid loss of mandible volume. So think about those people who, we all think of grandma with her dentures out and that the whole facial collapse, that image is just in your head. And so the more you lose your dentition, the more you're going to lose gum volume, the more you're going to lose mandible volume and maxilla volume. So initially the concept of filling, well, first we had facelifts, which were pulling, right? And that has its own problems. It can be helpful, but it also we've learned that we need to balance. And so fill and pull is going to help us give us more youthful looks.
Okay.
And a lot of the studies would initially they like looked at daughters and mothers to see the differences, but now they've been doing them long enough that we've seen like the same people and followed them and aging. So
That's amazing.
Yeah, it was really cool. One of the plastic surgeons, Dr. Lambros, he actually at the plastic surgery meeting would get us to do facial image analysis every time we went to the meetings. And so, you know, when you've been going to him for 20 years, you know, he's got quite a bit of following people in their aging process.
Wow.
It was really cool.
Awesome.
But then he also did MRIs to look at that. So these fillers are going to help to kind of build structurally. And we have, honestly, it started way back in the 80s when they were actually injecting liquid silicone into patients' faces. And I highly do not recommend that, because imagine with aging, our bodies are changing. And so what looks good today might not look good 20 years from now. And so definitely in my mind, the semi-permanent and then the dissolvable fillers are what you're going to want. Do not want to be messing around with those permanent things. We've all heard terrible horror stories of people putting crazy things in their faces and whatnot. So the nice thing with the dissolvable fillers is if we do something you don't like it, you can dissolve it. Or if you do something and maybe it's something that unfortunately has a complication associated with it, well, then you're able to dissolve it. And so
I actually have Juvederm in my lips, but it's been, 3 years since I've had filler, and I have had migration. So what causes that?
It's hard to know exactly what you're seeing when you say that you have migration. It could.
Okay.
So
this is about to be weird, but can I show you?
Yeah.
Okay.
So you're actually saying that you have like a little worm. Yeah. So that may not have been migration. That may have been the original placement of the filler. And that you just didn't notice it at the time, but now that it's kind of walled off a little bit in there, now it's more noticeable, more evident, and things like that.
Okay.
So you absolutely can dissolve that, and that is easy peasy. It doesn't hurt me one bit to put a needle in your face.
Okay. Good deal.
So like I said,
I need to come see you.
I didn't know if I wanted to be a doctor because I didn't like needles, and then I realized it doesn't hurt me at all in order to
stick a needle in my face.
But yes, so we do have a dissolvent for like Juvederm, and that's another reason why I do really feel like a lot of times we want to use something that is dissolvable,
100%.
because then it's something that if we do have something like that happen over time, we can do that. So we tell you that Juvederm is only going to last 9 to 12 months, but you said you did this 3 years ago and yet you noticed it. So we absolutely can get a little bit of scar tissue around the fillers, and the body can kind of wall it off, and then it doesn't dissolve. So I think there's two ways to think of that. One, if it bothers you and it's noticeable, then we definitely want to dissolve it and get rid of it. And then for the other people who, if it's in the right place and you like it, well, you are so blessed. You now have a long-term filler that is giving you the place that you want. So, and it really, I really deal with it basically on what the patient wants and what they're thinking. So I have that as well in one spot, but I'm like, but that's perfect because now I don't have to poke myself in the lips and get
there you go.
But if we have that, absolutely, it can be dissolved. And if it's something that is bothering someone, we can get rid of
See,
that.
the thing is I want to get them done again.
Oh yeah.
So, but
So some people will tell you that you have to dissolve something like that before you get filler again. I disagree. I think you can, if you're wanting to reset everything, then certainly you can dissolve it if you want to.
Okay.
But why not just build on the framework and the foundation that I already have?
Okay.
So I don't necessarily feel like you need to do that. Some practitioners do. And I just tell patients what you want to do is find a practitioner that you feel comfortable with their body of work. You know that they're medically trained and that they hopefully aren't just a housewife who went to one of these hotels and did their training in one of those conference rooms. Please go to someone with a medical background. And my nurses are my best injectors. My nurses inject me. So it's not that you have to go to a physician. You can definitely go to somebody, but please go to someone who has experience, who knows what they're doing, understands the complications, and can tell you what they're going to do if you have some of those complications. Because that's the main thing is it's all well and good. Anybody can inject somebody with something, but what are they going to do if they have something go wrong? So just really make sure that you sit down and get the philosophy of your injector. And if they want to, if they say, well, this is going to make it harder for me to get the shape that you're looking for in your lips, I want to dissolve that. Well, then they have a reason for it. Yes. On the other hand, if you're like, oh, I love the shape of my lips, but I just want a little bit more volume. Well, and where you have that little bit of filler that's still there, we can still build upon that and get a good shape, then great, leave it.
Okay.
And maybe different people, every one of us who comes on here is going to have a different opinion with that.
Yeah.
So that's why I say just make sure that you feel like you have a good rapport with your injector. Make sure you guys have the same philosophy and that they're well educated and know what they're going to do.
Okay.
So in terms of the fillers, though, so for instance, you said you had Kiss. So Kiss is going to be more like our Volbella, and that's going to be our softer, lighter filler.
Yep.
And that can be really nice, particularly if we're going to be injecting more superficially, kind of in the pink vermilion. That soft skin is going to expand beautifully. It's going to have a lot of shape change and things like that. But then we have people who come in who really want to have maybe some aging things corrected. So lift is going to be fine, but I do like a thicker, firmer filler for like more of our marionette lines, supporting the corners of the mouth, giving a change into that downturn of the corner, so that we can help lift it again, so that they're not starting to get those marionette lines that we call them. And so that thicker the thicker the filler, the more we're going to be able to lay that at different levels. And that's where it's important to have an injector who knows about those different things. For instance, oh my God, fillers and Botox are all over social media. You can see so many different people, and I love following them myself just to see what people are talking about. And so if you're wanting to actually do different shape changes, you are going to inject in the muscle. You're going to actually, and then there are people who are like, oh, I'll never do that. Well, in the right hands and the safe person who knows what they're doing, it's going to be okay. But if somebody has really, really thin lips, or somebody has a scar that we're wanting to fill out or something like that, then you have to use the tools that we have in different ways and be comfortable and know what you're doing.
Yeah.
So, right.
That's going to be, so again, so that's our Volbella, and that's going to be like our Kiss. And then we have like our workhorse, which is our Juvederm, like you talked about. And so that's going to be really good for marionette lines. It's going to be great for nasolabial folds. It can be used in the cheeks as well, but then we usually kind of turn to our thicker fillers, which is going to be like our Voluma or our Volux. Those are going to have our more lifting capability, where we're really going to be able to build up a much stronger change. So like I said, creating chins or jaw lines or cheekbones, and those are going to be deeper and down on those areas. So and of course our softer ones, the Volbella and the Juvederm, are going to be good for like our liquid rhinoplasties and making small changes. And I would say that you have to be very cautious if you're doing any of the noses. You really want to go someone who does a lot of noses, because there's a lot of blood vessels in the nose, and so that's where we see some of our most dramatic occlusions of blood vessels and complications. So make sure you're going to someone who knows what they're doing, and make sure you're very cautious with that. So that's going to be kind of our warning area. And the reason for that is because some of those blood vessels around our nose actually connect to the blood vessels of our eyes.
Oh, wow.
And so if you get an occlusion in a blood vessel, it's one thing to get like a scab and some wound healing problems. It's quite another to go blind. And so that's where I'm just a strong proponent of making sure that people are medically trained and that they've done a lot of it and know what they're doing.
Agreed.
So, and that they have an emergency kit. They know what they're going to do if you do have a complication.
Yeah,
so.
Absolutely.
Okay. So for fun, you guys can actually see the differences between the different fillers based on when we inject them. Okay, so we're going to do and show you this right here. So this is Volbella. So this is one of our thinner fillers, and so I'm going to just kind of show you when we push that out. It's very soft, and you can kind of see that it just kind of lays flat. And when you touch it, it's going to just be very liquidy and very flat and soft. So here I'm going to do that again, so you can kind of see it when we drop it in there. It just kind of puddles, and it's very soft.
Oh yeah.
Yeah. So it's the best way that I can describe it, and we'll do it again for you. So, so the best way I can describe it is it's kind of like different layers of if you're making a cake or cookie dough or something like that, you're going to have different thicknesses. And so if you're making a cookie, it's got, you can roll it up into a ball, but you can't make a cake mix roll up into a ball unless you add extra flour or something like that. And so this one, So this is more of our voluma. And do you
Okay.
see how it stands up as a ball and it didn't puddle? Oh, look, show that on your finger. Show it. So you can really see that it holds its shape. It holds it holds the lifting. And so see how it just stays in that shape instead of flattening and just dissolving when we pet it and just like spreading out. You can see that extra cross-linking has made it have more durability, and that actually has that lifting capability. So that's kind of why it's so helpful to have those different tools in your toolbox to be able to treat different parts of the face. So what other fillers have you heard about?
So like the Restylane.
With the hyaluronic acid fillers, there is the Restylane family is the other big family, but you also have RHAs, and they have 1, 2, 3, 4, so they're going to be the same sort of thing. But there are those are the most common ones and the most well-known, but there are other ones and being developed in other countries. So you will definitely be hearing and seeing about that. In terms of families of fillers, though, just wanted to let you know. So I thought maybe you would ask me. So the other thing that you may hear about now are what they're calling collagen stimulators. They're not like the fillers per se, but the most common one that we talked about that we hear about is Sculptra. And so Sculptra is actually a liquid. And so it actually has a component of vicryl sutures. So what we used to use for dissolving sutures, it has like little particulates of that. And so you rehydrate it and you fill it back up and you use those vials. And so just like if we put saline in your face and injected your face with saline, you're going to look better, smoother for a while, but your body's going to absorb the saline.
Right.
Well, inside those vials, we rehydrate them, and then you can actually use that to fill like broader areas, because we're typically using like 5 vials of it. But because it's more of a collagen stimulator, it's not going to give you a filled look. It's not going to give you a cheek. It's not going to give you a chin. It's not going to give you a lip. It's basically to help encourage collagen stimulation so that you can have buildup of your own tissues. Hopefully will build up more collagen and make sure that you just look more rejuvenated and youthful. And your body then builds up the collagen with it. So that's kind of the other kind of filler. And then calcium hydroxyapatite is basically a tiny particulate of bony structure, but they've got teeny tiny little spheres of that, and so that is mixed into with your filler. And the reason people like that is they say that calcium can kind of mix in and irritate the tissues to create more collagen as well. And so that's going to be more of your radius. And some people will hyperdilute radius, and they'll mix it with the saline to try to also do like they'll use it for necks, they'll use it for backs of hands, things like that. You can still do that also with your hyaluronic acid fillers, hyperdilute it and do the same sort of treatments. But it is one of the things that more niche that the radius themselves kind of advertise as hyperdilute radius or calcium hydroxyapatite. So so now to your question, I just wanted to make sure that you guys knew about those fillers. And the thing that I want to encourage people to do is just like we're talking about fat grafting to the breast, fat grafting to the face. So that we can actually try to do and recreate some of the deeper structures with fat grafting, so you're not constantly going back for your fillers. Now, obviously, fat grafting is not going to work for superficial structures, for this thin skin or things like that. We're just putting it deep and trying to help recreate the fat compartments that you have that we've lost as we've aged.
So whereabouts on the face do you?
So cheeks are going to be the main thing, just trying to rebuild, because that the loss, again, the piriform aperture opening, and then the loss of our volume of our maxillas and our cheekbones, that's going to be the best place for it. So it's going to really help with that. So and I like that because that's surgery. So anyone can do fillers, but not everyone can do fat grafting. So now when we talk about the toxins, so we have so many great options for toxins, and we've had less options here in the US than they've had elsewhere, just because Allergan with Botox has really captivated the market. But as you mentioned, there's Dysport, there's Xeomin, and now Latibo, which is going to be from Korea, and it's been out for 10 years, but Allergan has really kept them out of the market, and so now they're coming as well. So in terms of your toxins, they are going to have pretty much similar molecule, but then they have more or less of the peripheral component of the botulism toxin that maybe you don't need in order to bind to the receptor.
Okay.
So that's what makes them different enough that they could be sold, since Botox was the first and you get trademarked, right?
Yeah.
And so Xeomin and Dysport are going to be, each one of them will have a little bit different chemical structure, but they're all working in the same way.
Okay.
And what they're doing is basically binding to on the muscles between our nerves that fire the signal and tell our muscles to animate. A little transmitter, when I say frown, that nerve lets go of the neurotransmitter to tell my muscles to contract.
Yeah.
And so if the Botox now binds to the receptor, the message can't get there.
Okay.
And so if the message can't get there, it's how long it stays bound to those receptors, which determines the longevity of the Botox or the Xeomin or Dysport.
Which is different for every patient.
Exactly.
Yeah.
And so, like, for instance, with men who have very big corrugator muscles who frown a lot, they're going to need a higher dose than women who have smaller muscles.
Right.
And so I also call my hyper animators. I'm actually a hyper animator because, like, if I don't have Botox, I have if this is
us too. Like,
Same.
I need to go back and get mine done again because I'm like,
so for hyper animators, I say, well, maybe you're going to need a little more as well. But it's very important to realize that all of these are dose dependent. So if you use a dose that is smaller than the dose that you need to fully paralyze it, it's a bell curve. We know that if you use less, then you're going to get your animation back quickly. More quickly, and you're gonna or maybe still have some movement and some animation, even though you've just had your toxin.
right.
So based on that is going to determine on whether or not how many units should we use based on what does the person want. So if somebody says, like, I really don't want to move in here, I really want to be frozen, well, then we need to use typically for Botox 20 units, and then I believe for Dysport it's 40 units, so you just double it. And so you're going to use the amount of units at 20 units of Botox for your glabella. 80% of people are going to have full paralysis for 3 months. But that means 20% of people are going to probably need more. And so what I tell patients is, the first time you're having it, we are going to, if they don't have a lot of animation there, we're going to start with 15 units. I'm like, I would love for you to if 15 units are going to last 3 months for you and give you good paralysis, we're going to save you 5 units every time you come in here because we started low and we know that that worked for you. But if it doesn't work for you, it doesn't mean it didn't work. It just means that we should have gone up to 20 and we should have started there. Or let's say someone's a super animator. I say, we'll start at 20, but maybe we need to go to 25.
Right.
But what we want is eventually for it to be like a Big Mac. You come in, you order a Big Mac, you know what you're getting, you get it. And we would like for your Botox to be that way too, so that you're happy with your plan. And so we take pictures.
It's consistent.
And it's consistent. So we take pictures of what the patterns are. And depending on what people want to achieve, some people come in and they're like, well, I want to have an arched eyebrow, or I want to have my eyebrows have always been straight. I want to keep them straight. Okay, well, we're going to kind of work on that, whether we're treating crow's feet or the glabella or forehead. And sadly, as you get older, if you keep treating your forehead, that's what raises our eyebrows. And so sometimes we have to explain to patients, well, if you don't like having your eyebrow low, we shouldn't be treating your forehead as much. And making sure, I always say a monkey could give Botox, really, because there's not really much of a complications or downsides with it. But it's the art of it. It's the artistry. It's making sure that you're doing, listening to the patient. What do they want? And what are they hoping to create with that? And so that's the creativity of it.
So I have a question because I get Botox for my migraines. I have really severe migraines.
Oh, yes.
And bad TMJ. And so I feel like a lot of my facial structure has changed a little bit just like over time. Cause I mean, like my eyebrows, they don't have a raise, but I also don't feel like they're arched as much anymore. What would you say for those sorts of things if I'm having to get that for a medical treatment and then?
So unfortunately, because like you said, you're doing it for medical treatment, you're doing it for migraines. And so you want to keep getting that Botox.
Yes.
So if you want to have a more lifted or raised brow and you want to paralyze your forehead, then the only way that you're going to really fix that is going to be through either surgery, doing a brow lift. I
Okay.
know. You could try threads. I'm not as big of a fan of threads because
Okay.
unfortunately they you pay a lot for them and they don't last very long.
Okay.
And a lot of providers, now there may be wonderful providers out there who can get a lot of longevity with them. And I say kudos to you, and that's amazing. That's wonderful. And I would love to learn how you do that. But a lot of providers don't get a lot of longevity with the threads. And by the time you've paid for, just one threading for $3,000, you could have had a brow lift. On the one hand, if I have patients who tell me I am absolutely never going to have surgery, Dr. Brenna, I will pay for as many fillers as you want to put in my face because I'm never going to have surgery. Okay, well then by golly, we're going to do that. But I'm definitely going to educate my patients if they come in and they're wanting to camouflage because they have fat pads that are protruding in their lower eyelid and they want to camouflage that. I'm like, okay, we can do that, but really you're going to need a lower eyelid blepharoplasty eventually. If you're not ready for that, great, we'll do fillers for you. But I want you to know and remember that when it seems more cost effective and you're not getting as much camouflaging of those fat pads, you would do better, maybe wallet wise, to have a surgery. And I think people are shocked when I do that because they're like, well, you should just take my money. And I'm like, no, actually, we don't want to do that because I don't do lower eyelid blephs. So I'm going to send you to somebody else. So I'm definitely I don't care. I want what's best for you. And I do think that, so unfortunately, yes, could you do threads? Could you try maybe fillers along the brow line to try to help raise the eyelid itself, but all of those are going to be temporary and you're so young. So when I start doing the math for you, I'm like, well, if you really want your brows higher, then maybe you want a little bit of a brow lift. And so that it is sometimes scary to say surgery, but at the same time, I always want my patients to be as educated as possible. They need to know all the options, and if they choose fillers, great, we're going to try fillers. And then if they don't want them, then we're not going to, do that. So. And what other changes are you just seeing a change in your
a little bit because I get quite I do the they do a lot in my masseter muscles, and so like even my husband when I got home, I feel like I did start to notice it probably this last time when I had my injections about a week and a half, 2 weeks after, and he goes, "Sarah, smile for me." And I smiled, and he was like, "Sarah, you're the corner of your mouth doesn't go up anymore." He's like, "What happened?" And I was like, I don't know.
Well, what happened then is if the corners of your mouth is not going up the way that it usually did, then so the facial nerve is like a fan, has 5 main branches, and it comes across your face. And so depending on where they're doing your masseter injections, they could have potentially gone a little bit too superficial and affected your facial nerve.
Okay.
And it could have just been placement, because if it's only one time, then it's more likely that it's associated with the placement of the Botox. The good news is it's going to wear off in 3 months. Okay. I always say to my patients, I go, the good news is if you don't like this, it's going to be gone in 3 months. The bad news is if you do like it, it's going to be gone in 3 months. So I think
you have to come back.
I think anybody who can find a Botox that lasts longer is going to be a gazillionaire, because everybody who does love their Botox, they nobody loves being injected and nobody wants to have come back in 3 months later. So but unfortunately, hopefully, if that's just a recent thing and only just right now, it could be that if they placed it maybe a little bit superficially and not in the muscle belly, they may have gotten one of the branches. So what brings our corners of our mouth up is actually the levator muscles. And they actually run in a diagonal fashion across through here. And so if maybe they just put that a little too high, one of the branches the facial nerve is maybe just blocking it. And so we actually see that sometimes with smiles. And so like we look at her lips, and she naturally, even in repose, the corners of her mouth go up, right? And so in repose, yours are either straight or a little down, and mine are straight or a little down. So all of us are a little bit different. Well, if somebody has a downturn, like my mama when she was 80, she hated it. She was like, people always ask me if I'm sad. I'm not sad. I'm just not smiling.
It's like, you look like you're not as happy. And I was like, I'm happy.
Yes.
I'm happy.
Yes. Okay. And so like, that's also where, for like, we call the RBF, so getting rid of those is going to be so nice, because people are like, I'm not upset. Why do they think I'm always mad? And so being able to, I like to say that what we're trying to do is eliminate negative emotions. So we want, so sometimes people are like, I love my crow's feet because I've earned them. I'm like, great, absolutely. You earned your crow's feet.
Yeah.
That's all the years of smiling. And I
Yes.
love that. And then other people want every little crow's feet gone. And you can't get rid of every little crow's feet because when we smile, we push up on that skin and it's going to crease it. So with crow's feet is to help keep you when you're squinting that you don't see them. But I digress. So when we're doing the Botox on the corners of the mouth, if somebody comes in and they have bad marionette lines, I say that the combination of taking care of the muscle as well as filling. So if you do Botox in the depressors here, you will stop if you have tone that constantly pulls down on them. It's going to soften them. It's going to let those corners kind of rise up again. Now, if you don't place it right, you can, if you place it too far over or too low or whatever, you can actually end up hitting the nerve that when we smile. So you actually, instead of being able to pull down with your platysma and drop your lip and show your lower teeth, it knocks that out and your smile comes up. And so you can get a crooked smile.
Okay.
And so the good news is it's going to wear off in 3 months. The bad news is it's going to bug you for those 3 months.
Yeah.
But that's why it's super important. And that's why I said with the fillers earlier, I really want, if you're going to go to someone, that you go to someone medical. Because I can't tell you how many times, like I just saw a post where the lady showed how the person got a crooked smile because they put the Botox on the side that was correct. She was claiming that the other side that came up was right and the side that was down was wrong because obviously the lip wasn't working. And I was like, you are so wrong. You're out there putting this on social media and this lip isn't working. And that's why it goes up. The depressor is no longer working. And I'm like, so it's frustrating because even people who know what they're doing put it in there wrong too. So the people who don't know what they're doing, especially, we just want I want people to go to people who are educated, who know what they're doing with their fillers and Botox.
Scary.
So, but you said something very interesting because you said, what's the difference between fillers and Botox? And what people have to realize, like, and my mom, she was always reminding me that super intelligent people can get overwhelmed with this stuff because fillers are going to plump. Fillers are going to replace volume that you're losing. And so when we have an area that has lost volume from weight loss or aging, the fillers are going to help you. If somebody has something that's an animation thing, so the RBF, the frowning, the glabella, the downturns of the corners of the mouth, crow's feet, neck, platysma lines, that's going to be our Botox. That's going to be our neurotoxin because we're going to soften those lines, help prevent the muscles from animating or over animating.
Right.
Fillers are going to help fill the defects. And so we can get people who have had the RBF for so long that when they're not animating, they still have skin creases. Very carefully, you can fill those areas with filler, but you want to use Botox to keep them from remaking those skin creases.
That makes sense.
So yeah, so it's funny because it's so much stuff and we
Wow,
throw it all around
Yeah.
and people when you look at these before and afters, you're like, well, what did they have? Like I love it when people actually break down their treatments and tell you in their posts, okay, so I did this filler here and I did Botox here, and because then it is more helpful to educate people to see how are we achieving those results.
Yes.
Right, for sure.
Kind of neat.
That's so interesting.
I
See,
love
I'm
that.
learning so much because
I know.
I did not know.
Me
Yes. Wow. So what is your preference, or do you really just, it's kind of patient choice?
Yes.
Okay. So you don't really make any recommendations on
Yeah.
what your
So
stuff is?
that's the hardest thing. I saw an episode once and you guys are too young to have seen this, but did you guys ever see Dr. 90210?
My mom
See,
used to
you
watch
guys
that.
are so young. But it was a doctor, and he was not even a board certified plastic surgeon. He'd just come out of residency, but he was very flamboyant, so he did this TV show. But I just killed me because he had a patient on his table who came in for breast dog, and all she wanted was a breast dog, and he's like, "And your nose, we need to work on your nose." And I was like, "Oh, don't do that. That's terrible." So because something that wasn't bothering her at all, he pointed out. And I really think that in what we talk about, like what you said, what do we want patients coming in the door or leaving? I want people coming in feeling better about themselves than they ever did before. And so the most important thing that I ask my patients is, what's bothering you? And you would be amazed. You would have someone come in who has the worst, terrible eye bags, and you think that's surely going to be their number one. And they'll tell you that maybe it's not. It's like their lines in their neck or their marionette lines. And you're like, Okay, so we're going to focus on that. And then we build a rapport, and then maybe eventually we'll talk about, let's see, I'll mention, here's what some of the things that we can also do for you. But in general, I usually hand the patient the mirror. I ask them, look in the mirror, and I want you to tell me what it is you see. And I want you to be very careful about it. I want you to be very precise and start at 1, 2, 3, and let's work our way down it, because I feel like we can build a comprehensive plan for each patient, but I also want to know what's bothering them, because something that may not bother them may bother me, and I want to make sure that we take care of that for them, because we want to be budget conscious. We want to make sure that if they only have a certain amount of money to spend, that we focus on that. Now, if somebody comes in and says, Dr. Bennett, I want you to do exactly what you think I need, I will say, that's great. I still want you to look in this mirror and talk me through it. Because I do want to see, because people talk right now about full face rejuvenation and that they just do it. Well, you can't just go in and do what you think makes them look rejuvenated, because that may not be what they're seeing. So it's so important to really sit down and analyze it. And then one of your other ladies who was talking said, I think I have a little bit of body dysmorphic disorder, the breast implant lady. And I think that that's very important. You need to identify those things. And if somebody just comes in and you just do whatever you want to them, you are asking for a whole lot of hurt if you haven't really figured out what that person's like, what that make sure they have good expectations, because it's not a magic eraser. We don't have a magic wand. And so we're working within the confines of the aging process that they've already had, what they're willing to do afterwards for upkeep. And so I think it's so important to make sure you do a full consultation and really evaluate what they're bothered by, and making sure we're addressing those issues. So you're going to like this one. I say that for rejuvenation is like going to the gym. Yeah. You can't just do Botox and think you're going to have a perfect face, because you can't just go to the gym and work your biceps and have great abs. Right. So the face and the body is multiple levels. Different things are affecting it. So Botox is going to help with your frown lines, your crow's feet, your downturn of your mouth, but it's not going to fix your volume loss. So you've got your fillers. You got to fill with the fillers. But then what about your brown spots and your age spots? Well, that's not going to be helped with either of those. Right. So then you've got to work on your skincare, your lasers, your photo rejuvenation, your moxies, and you've got to work on skin texture. I'm texturing. I can't tell you how many times people come in with terrible texture and they want me to fix their skin with a filler. And I'm like, I can't put enough filler in your skin to get rid of that texture. So we're going to need chemical peels, laser peels. We're going to need something that's going to micro needling Vivace, so that we can actually work on that. So I love my gym analogy, because all my gym rats get it, because they're like, yeah, you're not going to suddenly have triceps just because you did biceps. Yeah, you're not going to suddenly have abs because you just did your pecs. Yes. Oh my gosh. So true. So you guys are so young and so beautiful. And so I have so many people such as you guys who are who will tell me, they're like, I'm never going to do anything. And then as we get older, we start going, well, maybe I'll do a little something.
See, when I got Botox and stuff, my mom's like, why are you doing that? Blah, blah. I'm like, for preventative. But like my injector, I've always told her, I want to look super natural. I just want preventative, and same with my lips. I'm like, I don't want to overfill. I just want a little bit of, I love her. She's great. And so like, I think it's important. And if it makes you feel better, it makes you feel better. Absolutely. And it makes me feel better.
Absolutely.
So there we go.
Well, I say it's like cosmetic crack. Once you start it,
you can't go back.
You can't. And I say that in a joking fashion, but it is true that it is so wonderful to feel your best, and so people do really enjoy the fact that this aging process thing isn't going to stop, and I just want to keep looking as youthful on the outside as I feel on the inside. Yep. And I think that as we have people who are now going to be older and older, I tell my patients there is a biological age and there's a chronological age. And I have the cutest little 90-year-old who came in who's like, I said I wasn't going to do fillers last year when I was 89 because I knew I wasn't going to need it anymore. But I feel like, you know what?
changed my mind.
And I was like, I love it. I mean, this
Yep.
woman hops up and down on the bed and she mows her own lawn and
Oh
she,
my
I mean, she's
gosh.
out there going and blowing. So why
Yep.
shouldn't you?
Yeah.
I just tell her, I go, well, honey, I have, 40-year-olds who come in here who are much less healthy than you are. And so
Mhm.
why shouldn't you get to feel your best?
Mhm.
Absolutely.
Yes.
If we want to do a little something, something, then we can do a little something, something.
Mhm.
I love it.
And I feel like our faces are our windows to our bodies and our windows to our
Mhm.
minds and our souls. And we spend all this money on fingernails and our hair, and then you've got folks who never do a thing and they smoke and they suntan and I'm like, oh my goodness,
Yes.
probably if do a little something for preventative along the way. And my sweet mom, the 80-year-old engineer here, she had 2 daughters who became plastic surgeons, and so her favorite birthday and Christmas presents were fillers and Botox and
I'm sure.
yeah, and so
That would be mine.
Me too.
and she was like, I wish I'd known. She's like, I knew well enough when I was younger to like protect from the sun and to
Mhm.
moisturize, and I knew those things, unlike some people her age didn't. But I wish I'd had this available to me, because she's like, if I'd started sooner, I could prevent the creation of those creases.
Yes.
And I
Mhm.
totally agree with that wholeheartedly. If you look, one of my best for my 50th birthday, I put the picture of Kate Blanchett on my
Mhm.
from the Golden Girls. I put
Yeah.
her picture, and I was like, 50-year-olds ain't the same anymore, because I mean, it's really true.
It's true.
Yeah.
Look at Jennifer Lopez. Look
Mhm.
at she's 50, and Demi Moore, just
Oh my
absolutely
gosh. Yeah.
stunning, and
Stunning.
she's almost in her 60s, right? And so we're I do think the more that we are aware of the things that we can do to live better and healthier
Mhm.
lives, I definitely think that it's all those things. Don't smoke, don't suntan, protect your skin, SPF, all of those things are going to be good for you.
Yeah.
Yes, absolutely. Oh
well,
my gosh.
Dr. Bennett, we are so happy you came on. We learned so much.
So
Sarah,
much
what do you
from
want to
you.
add?
Oh my gosh. I'm so thankful. And I seriously, if you would like to at another
Yes.
point, we can come back on and talk about
Yes.
so much more. So many more
Absolutely.
topics.
I'd love to. If there's anything else you want to hear about, I mean, we can all get into the nitty gritty. So that would be
Cool.
wonderful. I love it. Thank you for this wonderful opportunity to share with you
Of
and
course.
share with
course.
your viewers as well.
Most importantly, thank you so much for what you do for women and
Yes.
for patients.
Thank you.
I mean,
I love
especially in this
your
West Texas
your
community.
perspective and your why behind, and I love that you touch on how you want your patients to feel when they leave, not when
Yes.
not when they walk in.
Absolutely.
So,
I think it's all about empowerment. And I just, I think that we need to build people up so much more, and we're so hard on ourselves, and we're our own worst critic. And I think sometimes for people to be able to hear from a plastic surgeon that 99.9% of people, that they look better than them, and realizing that they are, beautiful creatures, and knowing from the inside out that they can represent the best self, their best self, is going to give them that much more empowerment. I want to give that to patients.
I love
Right.
it.
So
Well, thank you so much. And then who
Thank
knows?
you.
Maybe we need to book an appointment and do like a vlog episode
Yeah.
with you.
Yes, absolutely.
That would
Come
be
to our
so fun.
office so you can also see what we have or whatever. It would be fun.
Yes, I'd love that.
That would
Thank
love
you so
it.
much.
Yes,
Alrighty.
thank you.
thank you.